So next we have David Dorr. David is the Chief Research Information Officer and Vice Chair of Medical Informatics and Clinical Epidemiology at Oregon Health and Sciences University.
Thanks, I appreciate it. So I am a health informatician as well as an internist. So no, my wife is an oncologist, but I know less about precision oncology. And I also was so thrilled to learn so much about this sort of integrated diagnostics as you all defined it. In my work, most of my time is spent really thinking about how we put advanced algorithms, so AI, with complex data into workflow so we can benefit from it. So I sort of redefine things in a lighthearted way here. And I'm really going to talk about the messiness of the world and how cognition and the data and its limitations and biases and then ultimately affect our ability to be successful, and then how we have a science called implementation science that really can be applied here effectively. So what is health informatics? Many of you, I heard pathology informatics before, but it's really trying to understand how we can use this data, information, and knowledge that we're generating to improve health. And it's multidisciplinary by definition. So it pulls from psychology, it pulls from computer science, it pulls from all kinds of understanding of health services research, but really with this data-driven underpinning. And so I'll talk about data biases and data issues and how when we're trying to implement something for somebody to pick up and use and make a decision on, how important it is that it is hardened to all of the problems in the real world. For cognitive biases, people's understanding of the data, like trust is going to be discussed, understanding of not just the data, but the context in which it's applied and how much they trust the system that you've put in front of them is so important. But there's other factors too. Someone else will talk about trust at length. And then implementation science, what is it? And then I'll talk about at OHSU how we've tried to put this into something so we have a way forward. Because actually, in my job, as Chief Research Information Officer, I provide leadership, support for innovation, and try to improve service very much in the space that you all care about, which is bringing these multimodal data sets to bear. Like, how can we scale this and make it available for everybody and then get it to the point of care where it's useful for patients and actually where patients can understand it. My research team focuses on really understanding how people who are vulnerable in particular ways, so usually people with complex conditions that aren't met well by our standard health care, can be identified, and either through risk stratification or segmentation, and then how can we tailor care to these needs? So there's an excellent parallel. I do it in primary care for people with multiple chronic conditions mostly, but it's actually quite similar in some of the things that we have to know. And then I look at evaluations to understand how we can improve outcomes, but also how our implementations go and how can we improve the uptake? How can we get people to pay attention to these things? So in general, I'll say, like, from an OHSU perspective, in Oregon, we are very eager to implement these advanced algorithms. There's lots of interest to do it, and it's frustrating. Sometimes I hear this a little bit, how hard it seems to be to do, especially at the point of care. Here's like, and the NAM has covered this before with this artificial intelligence in healthcare, the hope, the hype, the promise, the peril. I think that's sometimes what we think about. But even in this big review of deep learning, you see they've got pros and cons for every result. So there's all this nuance that just doesn't lend itself to this sort of global evidence as a single factor, but has to be interpreted. And that is one of the hardest parts. So thinking about that, when we think about cognition, how do people interact with information that's presented to them and then decide to act on it in particular ways? How do they pay attention to things? And I really like this AIM Act idea, which came out of Dr. Nahum Shani from Michigan, that sort of incorporates a lot of things. So affect, so AIM is affect, integration, and motivation. Basically, you need to have some kind of emotional response. Now, if you're an oncologist caring for somebody and you see integrated diagnostics that may be pertinent for your patient, you really want to apply that. So maybe the affect is not so hard to hit here because you're passionate about how you care for patients. But then you have to integrate it and then be motivated to take action. We have to think about when the right time and place to provide that and how we provide the messages. This is important for your patient. It's important now, but we only have so much attention, and that's a huge issue because if we overwhelm people with a big report and it's unclear what's happening, then people may not pay attention to it, put that into the context of that particular patient, sort of figure out how it relates, then that motivation, which could be high, is never translated. These are really important constructs. And so issues around trust and understanding, but also in terms of prioritization, what's most important here? How can we help people engage with the information through adjudication, for instance? And what action could be taken? Those are so important to put into these syntheses. So we've studied this in other risk scores, and in a very large trial of several thousand clinics, actually, who were all required to risk stratify their patient by their likelihood of ending up in the hospital or dying in the next year. And they created algorithmic risk scores largely through similar techniques you've described, but they also had some clinical intuition. And what we found is the people who could adjudicate, bring those together and say, hey, for this patient, this didn't work, but for this patient, it did, and that was very obvious, then they were really much more successful. They liked their risk scores more. That was a big problem because many people didn't trust or feel confident with their risk scores, over half the clinics. The other thing that we find that is data collected for other purposes is messy, and all the algorithms really have to take that into account. So when we did reviews of just standard diagnoses, we found errors as high as 30% of the diagnoses we couldn't justify, especially if we were only using sort of rules that ignored the diagnosis codes and we're trying to use the core laboratory data, for instance. It was just missing. And it's not missing at random. It's inequitably missing. And this affects us in lots of ways because if we apply these algorithms, as in this Obermeyer paper, we might think that, for instance, in this case, for risk of future utilization, the black and white populations here from the science paper would equal risk, when in fact the outcomes for the black and white populations were much worse for black populations, even as the risk was predicted as equal. You've covered this very well with these differential sort of background, and we need to have that data in our data sets. Otherwise, we have a real problem. And access to healthcare is one of the biggest aspects here, that people have very differential access to healthcare. So finally, how do we put this together? So there are ways to study this very comprehensively. It's moving quickly. The one I like the best, although there's a lot there, is this consolidated framework for implementation research. Let's say you've got an amazing sort of way to think about particular diagnoses, really bringing more nuance in there. How are you going to really change the care that is provided to those patients? What are the core components of delivery, of identifying when and where to do that? And what's adaptable by the site for different aspects? And then how do you have to think about the difference in context and let each team and group and institution sort of adapt it themselves and teach themselves how to do it in order to get long-term implementation success. So if you have something that has some reasonable evidence, you need to make sure that happens. And one of the most fun things I did recently is I was editor-in-chief for this issue of ACI Open, where we had 12 emerge sites that were trying to deliver genomic information, clinical decision support to people, and really struggled with those lessons. Like, how do we help people understand this? How do we provide access to it? I know there's some great work going on here, but this is one that has to be addressed. So what we did at OHSU is anytime there's an advanced algorithm, call it machine learning or AI. It's got to have some utility, right? So this is not just pure research. We're applying it to clinical care. We have to think about the risk and benefit. Are there potential biases? How was it developed? The ethics related to that, but we have to do it locally. And so, we think of this as sort of our own code of conduct, which National Academy of Medicine we've been talking to them about starting a similar AI code of conduct. Because we all are responsible, really, ultimately, for it, not just the developers, but every implementer. And I love this article. There's no such thing as a validated prediction model. It's a little tongue-in-cheek, but you can't stop and say the validation is done because things change so quickly. Each new site, data changes over time. We learn more. I think that's really important. And with that, I will end. This is San Juan, Puerto Rico, where I was recently. Thanks.